So, hello everybody. My name is Meinolf Suttorp. I'm a senior professor at the medical faculty of the Technical University at Dresden in Germany and the retired head of the Division of Pediatric Hematology and Oncology at the Children's University Hospital. Together with my co-chair, Nirmalia Roy-Mullik, Professor of Pediatric Hemato-Oncology at the Tata Memorial Center in Mumbai, in India, we are grateful to the iCMLf and especially to Professor Beppe Zaglio from Italy for setting up this series to transfer existing knowledge to interested physicians around the globe via the internet. In addition to the existing first module on pediatric CML, we now have the pleasure to add a second tranche of 4 presentations from experts in the field. The first presentation is given by Deepam Pushpam. He's Assistant Professor of Medical Oncology at the Department of Medical Oncology of the All India Institute of Medical Sciences, located in New Delhi in India. Besides CML, his area of expertise covers the broad field of pediatric and adult hematological malignancies, including stem cell transplantation, as well as pediatric solid cancer. In his review, published in the Indian Journal of Medical Research in 2019, he raised the question whether pediatric CML really is a disease different from adult CML. This is also the topic of his presentation for this module of the Pediatric iCMLf Knowledge Center, and it is entitled Differences Between Adult and Pediatric CML. Professor Pushpam shows that children affected from CML have, in contrast to adults, a higher white cell count, higher peripheral blast counts, lower hemoglobin, and a larger spleen. Advanced phases of CML are diagnosed more frequently in children, and they exhibit a less favorable cytogenetic and molecular response. However, there is no difference in survival, and the dose of imatinib influences response and outcome apart from prognostic scores. Also in children, the aim should be to achieve treatment-free remission, and results from small pediatric cohorts are similar to adults, where treatment-free remission has ranged around 50%. The second talk is given by Markus Metzler, who is the head of the Department of Pediatric Hemato-Oncology at the University of Erlangen in Germany. As my successor, he is chairing the trial of pediatric CML within the Society of the Pediatric Oncology and Hematology in Germany. For many years, Markus and I have closely collaborated. Investigations on the molecular background of pediatric CML coming from his laboratory have provided a deeper understanding of the reasons why a disease manifesting typically at older adult age can also affect children. In his talk, Predispositions and Genetic Factors in Pediatric CML, he presents data on germline DNA variants, which increase the risk to develop CML at younger age, but also have an impact on therapy. Somatic variants, which are present and accumulate in the leukemic cell clone, exert a significant impact on the prognosis and also modulate therapeutic success. When in adults, more than 400 CML patients and more than 1,000 healthy control individuals were analyzed in a genome-wide association study, defined haplotypes and a genetic score were significantly associated with a predisposition to develop CML. Interestingly, the score was associated with age at diagnosis, and the average number of risk alleles was significantly higher in younger patients. Thus, pediatric CML may well be described as a leukemic entity of adulthood, with rare occurrence in childhood, but a specific pediatric biology. The next presentation is given by my co-chair of the Pediatric iCMLf Knowledge Center, Professor Nirmalia Roy-Mullik. He's affiliated as a consultant at the Pediatric Hemato-Oncology of the Tata Memorial Center in Mumbai in India. This hospital is one of the largest cancer centers in the world, and takes care for more than 4,000 children with cancer annually. Over the years, Professor Mullik has accumulated experience on treating several hundred children with CML in the scenario of a resources-restrained setting. He is well familiar with the obstacles physicians and families affected from pediatric CML have to face in the low middle-income countries, such as delay of diagnosis and treatment, lack of TKIs and stem cell transplantation, and lack of multidisciplinary care. Professor Mullik has performed a survey in 31 centers distributed across 27 low-middle income countries to gain insight on pediatric CML management. He will present the results of this multinational survey in his talk, thus providing valuable insights to hitherto unreported multifaceted challenges, which comprise patient-related, physician-related, and infrastructure-related factors. It highlights the urgent need for developing context-specific guidelines for the low-middle-income countries and advocacy for uninterrupted access to TKIs and improving diagnostic infrastructure and resources. The fourth and last talk is presented by myself and focuses on the pediatric-specific side effect of growth retardation caused by TKI treatment and on endocrine side effects. Following the licensing of imatinib for children in Europe in the year 2003, the first case reports on growth impairment as an unexpected off-target side effects of TKI treatment were published 5 years later in 2008. Thereafter, many retrospective analyses on children enrolled in pediatric trials and registries have demonstrated that all TKIs licensed so far for children, namely imatinib, nilotinib, and dasatinib, reduce the cellular activity of the osteoblastic as well as osteoclastic cells. This results in an impaired bone remodeling as a central process of osseous growth. Children at younger age are affected more severely as they receive more treatment until the final height is reached, when the epiphyseal lines close shortly after puberty. On the other hand, pubertal growth spurt at the beginning of puberty partially will compensate the stunting caused by TKIs. As the median age of diagnosis of pediatric CML is 12 years, the majority of children on ongoing TKI therapy will lose approximately 1 to 2 standard deviations of their prospective longitudinal height. Data on the osseous side effects of bosutinib, ponatinib, and the new STAMP inhibitor, asciminib, are still missing. Therefore, the most important instruments of a pediatric physician, namely scales and a measuring rod, together with age and sex-related growth curves, will remain among the important tools when monitoring a child with pediatric CML. I hope that all the presentations archived in the iCMLf Knowledge Center will fulfill the expectations of the users. Let me stress that the ongoing support by Dr. Aline Harrison-Buchanan and Nicola Evans from the iCMLf is highly acknowledged. Without their work, the recording of the pediatric CML modules would never have been terminated. Enjoy the presentations and do not hesitate to ask questions via the internet. Bye-bye.